Hello, everyone. My name is Amy Liu, and I'm a Research and Quality Improvement Fellow at the San Francisco VA and University of California, San Francisco. Today, I will be presenting our work on the impact of longitudinal virtual primary care on diabetes quality of care. As we know, rural individuals experience higher mortality rates than their urban counterparts due to a combination of inadequate access to healthcare and socioeconomic disparities. This difficulty with accessing healthcare stems from physician shortages in rural areas, as well as a lack of health insurance. Rural areas have more difficulty recruiting and retaining healthcare professionals. A 2017 study showed that areas that were the most remote and with the greatest need for healthcare workers often saw the highest physician exodus. Thus, telemedicine has been heralded as a promising solution to address the supply to demand mismatch. Telemedicine strategies have been demonstrated in prior studies to increase access to care and improve clinical outcomes for single chronic diseases. One particular chronic disease that has a body of literature to support the effectiveness of telemedicine strategies is diabetes. However, most of the evidence comes from randomized controlled studies done in specialty care settings with strict exclusion criteria. This is far from the reality where the majority of diabetes is managed in primary care. And this is particularly true in rural areas given the limited availability of subspecialists. So the question is, can a primary care telemedicine program achieve similar diabetes outcomes as usual in-person care? The VA piloted such a delivery model in 2015 to reach its large population of rural veterans. This program was called the Virtual Integrated Patient Aligned Care Team, or V-IMPACT for short. The overarching goal of V-IMPACT was to supplement primary care workforce in underserved rural areas struggling with physician retirement and workforce turnover and retention. V-IMPACT is comprised of three main elements: a hub and spoke model with a remote hub of primary care providers, nurses, pharmacists, and social workers to supply the workforce needs of several rural spoke clinics. Hub providers take over entire panels of displaced patients. For example, when a rural primary care provider leaves the practice, his or her patients would be assigned to a V-IMPACT provider. Patients could also be assigned to V-IMPACT to offload existing large panels. These remote providers formed virtual patient-centered medical homes with the remaining on-site clinic staff to deliver longitudinal team-based care. Hub providers worked with on-site nurses so that patients can remain in their usual clinics. And by leveraging telemedicine, hub providers could see their patients through facilitated in-clinic video appointments. They also conducted quarterly site visits in person to supplement care and do procedures. After demonstrating initial feasibility out of Boise, Idaho in 2015, it quickly expanded to 10 hubs, as shown on the maps here, serving 44 spoke clinics. Implementation was staggered over 2 years, from 2016 to 2018. The aim of our study was to evaluate the difference in diabetes care in veterans before and after implementation of V-IMPACT at participating primary care clinics. We hypothesized that diabetes care delivered by V-IMPACT would be similar to in-person usual care. We conducted a quasi-experimental study of propensity match cohort of veterans with type 2 diabetes who received care in participating spoke clinics from January 2016 through September 2019. Participants were included if they had at least one primary care visit and have at least one documented hemoglobin A1C during the study period. They were excluded if they carried a concurrent diagnosis of metastatic cancer or received care at a clinic with unequal distribution of intervention assignment. The index date of exposure to V-IMPACT was defined by the calendar quarter in which a patient first participated in a primary care visit with V-IMPACT providers. Eligible control patients included all those who also received primary care during the same time but did not have any documented V-IMPACT visits. The pre-intervention period included up to 2 years prior to the index quarter, and the post-intervention period included up to 2 years after the index quarter. Since different clinics implemented V-IMPACT at different times, follow-up time varied among patients in different clinics. We collected data on baseline characteristics of our cohort, including demographic information, comorbidities, BMI, insulin use, and index quarter of enrollment as covariates to be used in a propensity score matching. Our outcomes of interest were the change in hemoglobin A1C, change in systolic and diastolic blood pressures, the percentage of patients with completed urine microalbumin testing, the percentage prescribed statins, and the percentage prescribed ACE inhibitors or ARBs. We use propensity score matching to select controls and balance baseline covariates between patients receiving impact and those who remained in usual care. We then performed a difference in differences analysis to estimate the effect of V-impact implementation on glycemic control and quality of care. We used a mixed linear effects model for continuous outcomes and bootstrapped linear regression model for binary outcomes. This flow diagram shows how we arrived at our final cohort. We started with roughly 250,000 patients served in these 44 clinics. We excluded 180,000 patients that did not meet our inclusion criteria, and that left us with 62,000 patients in our diabetic cohort, 4,800 of whom were V-impact. We removed patients from excluded spoke clinics, and after applying propensity score matching, this yielded 4,575 patients in each arm. In the pre-intervention period, patients in both groups had an average of 2 primary care visits per year, and in the post-intervention period, V-impact patients had on average 3.6 visits per year compared to 2.8 visits per year for patients in the usual care group. The majority of patients in both groups had both A1C measurements in the pre- and post-intervention periods. This table shows the demographic characteristics of our cohort before and after propensity score matching. As you can see highlighted here in red, V-impact patients prior to matching were more likely to be white and living in rural areas. And these are some of the select clinical characteristics included in our propensity score matching. The comorbidities here are only a select few that are relevant for diabetes, but we included a lot of other comorbidities as well. After propensity matching, baseline characteristics were all well balanced with a standard mean difference of less than 0.1. This graph shows the overall trend in hemoglobin A1C levels in the two groups over time. The x-axis here is time in calendar quarters centered around an index quarter, and the y-axis here is hemoglobin A1C represented as a percentage. The red line denotes V-impact, while the blue line denotes the usual care group. And as you can see, the two groups achieve very similar diabetes control over time, with a difference in differences estimator of negative 0.004%. Both groups over time average hemoglobin A1Cs trended downward. Similarly, this is a graphical representation of average systolic and diastolic blood pressures in the two groups over time. Here, the same x-axis as time centered around the index quarter, and y-axis is blood pressure in millimeters of mercury. And again, as you can see, the two groups achieved very similar blood pressures over time. This shows the percentage change in patients meeting quality indicators before and after V-impact implementation. We observed a 4.1% greater absolute increase in the proportion of patients prescribed statins in the V-impact group, and a 5.7% greater increase in the proportion prescribed ACEs and ARBs in the V-impact group. Both groups suffered a decline in patients receiving urine microalbumin testing, but there was no difference between groups, with a difference in differences estimator of negative 0.06%. The greatest strength of the study was that this was the first large observational study evaluating diabetes outcomes in patients exposed to longitudinal video-based telemedicine in real-world primary care setting. We showed that longitudinal virtual primary care is feasible to deliver to a rural population, and this care is just as good as usual care. A few limitations to note. Observational studies are inherently subject to bias given the lack of randomization. And though we used propensity score matching, there are several factors that were unable to be measured, such as the proportion of veterans who were co-managed by non-VA providers or subspecialists, in particular here endocrine specialists, as well as several variables that were unable to be calculated, like the length of diabetes diagnosis per patient. And finally, the results from our VA population and the implementation within the VA system may not be fully generalizable to other patient populations or health systems. In conclusion, the quality of diabetes care delivered by a longitudinal virtual primary care model was similar, if not better, than traditional in-person care. Thus, a model like V-Impact could be an effective strategy to increase primary care access in rural areas. And as such, the VA is actually currently scaling up this project by establishing hubs in each of its 23 Veterans Integrated Service Networks, or VISNs. With that, I'd like to acknowledge the VA's Office of Rural Health for funding the implementation, operations, and evaluation of V-Impact, the VA Collaborative Evaluation Center within the VA Denver Seattle Center of Innovation for its support in the evaluation work, as well as the VA Quality Scholars Program for funding and supporting my fellowship training. Thank you all for tuning in.